Good afternoon, and welcome to the Johns Hopkins 30-minute COVID-19 briefing, where we provide live insights from the experts who lead our work at the Johns Hopkins Coronavirus Resource Center. For the next half hour, we'll focus on what you need to know right now about the COVID-19 pandemic and public health responses. As part of this briefing, we'll have an opportunity for live Q&A with our experts, and we'll be offering these 30-minute briefings regularly on Fridays at 12 p.m. I'm Dr. Lainie Rutkow, a professor at the Johns Hopkins Bloomberg School of Public Health, and I'm part of the leadership team for the Johns Hopkins Coronavirus Resource Center. I'll moderate these briefings, and I'm excited to connect you with our experts. We'll provide answers in real time, so please submit your questions in the box at the bottom of your screen. Before I introduce you to today's guests, I'd like to briefly summarize the trends that we've been seeing. And to do that, I'm going to share some slides that draw upon data visualizations from our site. As you can see here, the US continues to lead the world with the greatest number of overall cases, as well as the highest number of daily new COVID cases. And the US is followed at a distance by Brazil, India, and then Turkey. On this slide, you can see some truly sobering numbers. Since our briefing last week, the US has set daily records for both new cases and new deaths. On December 4th, the US had a record high of 227,828 new cases. And a few days later, on December 9th, the US had a record high of 3,124 deaths, meaning that the country has now crossed the threshold of having days with over 3,000 COVID deaths. Finally, as you see on this slide, in most US states, new cases are on the rise. In fact, in roughly 80% of US states, we either see cases rising or no change. The country is now averaging about 200,000 new cases every day. And this past week, the US saw over 1 million new cases, which is the largest single week total yet. These numbers, quite frankly, are staggering, and clearly there is much for us to discuss with the experts. And today I'm very pleased to be joined by two guests. First, we have Dr. Brian Garibaldi. He's the medical director of the Johns Hopkins Biocontainment Unit and an associate professor at the Johns Hopkins School of Medicine. Brian will be giving an update about the treatment of COVID patients. Then Dr. Bill Moss is executive director of the Johns Hopkins International Vaccine Access Center and also a professor at the Johns Hopkins Bloomberg School of Public Health. Bill will give an update about vaccine development and policy responses. Brian, first I'll turn to you. You've been a frontline provider since the earliest days of this pandemic. In the last few months, how has the treatment of COVID-19 evolved, and how does this significant increase in hospitalizations that we're now seeing challenge any progress?
Well, Lainie, thanks for inviting me to be here today. It's a pleasure to spend time with everyone. I think there are really two big areas in which the treatment of COVID patients has evolved. I think the first area that I want to talk about is the pharmacologic treatments that we now have available. So there are a number of therapies we think have improved outcomes among our hospitalized patients with COVID. The first is remdesivir. So this is an antiviral drug that was the first FDA-approved treatment for COVID. And in a clinical trial that was sponsored by the NIH, it showed that people who were hospitalized who received remdesivir recovered faster. So they on average had a 5-day shorter time to get better from their COVID illness. There's been a little bit of controversy about remdesivir recently because there was a large WHO-sponsored trial that showed it did not impact mortality. And so I think it's fair to say that while remdesivir probably is not going to dramatically reduce deaths from COVID, given the surges that we're seeing across the country, if we have a treatment that can shave off a few days from someone's illness and maybe get them out of the hospital faster, I think remdesivir still has an important role to play in the current surge in our country. The other therapy that I think has made an important impact, particularly among the hospitalized patients who are sick and requiring oxygen, is dexamethasone. There was a large study in the UK that showed that dexamethasone, when given to patients who were on oxygen or in the intensive care unit, it actually improved mortality. And so we've been using both remdesivir and dexamethasone very widely in our patients who are sick enough to get into the hospital, and for dexamethasone if they require oxygen. And we think that this combination of an antiviral therapy, the remdesivir, which targets the virus and prevents it from replicating in the body, coupled with this anti-inflammatory medicine, dexamethasone, might improve outcomes and hopefully get us to a point where we can get people out of the hospital faster. The other exciting development over the last several months has been the advent of some monoclonal antibody therapies to treat outpatients with COVID. Now, these are antibodies against the spike protein of the virus, which is the way that the virus gets into the body's cells. And there are two different antibodies. One is a single monoclonal antibody. The other is a cocktail of antibodies that have been shown to reduce hospitalization if given to outpatients with COVID. And so those are both currently under an emergency use authorization. And it still remains to be seen how effective they will be at preventing hospitalizations among the many patients who are currently becoming ill. I think it's also important to recognize that we've learned a lot about what doesn't work in COVID in terms of therapeutics. So there was a lot of excitement early on in March and April and even to May about hydroxychloroquine. And I think we've now, through a number of different studies around the world, have definitively answered the question that hydroxychloroquine does not improve outcomes in patients who have COVID-19, and it also doesn't prevent infection if people take it as a prophylactic medication. But I think as important as the treatments is really how we've adapted to working in isolation environments. I think early on in the pandemic, we were uncertain about how safe the work environment would be for healthcare providers and how we'd be able to particularly deliver critical care treatments. And so, for example, as time has evolved, we've gotten a lot more comfortable in monitoring patients on a therapy called high flow nasal cannula, which is a way of delivering high levels of oxygen without putting someone on the breathing machine. And I think that's probably led to a positive impact among our patients because the ventilator itself can cause lung injury when someone's very, very sick. And I think we're also able to get back to a little bit of the same level we normally provide in a regular ICU. We've adapted to working in personal protective equipment and in these isolation environments. That's really something that's going to be challenged by the current surge as we begin to have more patients, as we run out of ICU beds, as we have to bring in providers who don't normally work either in an isolation environment or in an ICU environment. I'm really worried that we're going to start to see a rise in more patients having bad outcomes, particularly mortality in the hospital. I think that's going to be our greatest challenge over the next several months as we see many health systems become overwhelmed with COVID-19 patients.
Thanks so much, Brian, and really a pleasure to have you with us today. Before I turn to Bill, I want to remind our audience to please submit questions for our experts in the box at the bottom of your screen. We will, after Bill speaks, we'll move into moderated Q&A, and our experts are looking forward to answering your questions. Bill, we're now on the cusp of having initial doses of vaccine available in the US. There's even word that we could see an emergency use authorization as early as tomorrow. Can you please talk us through these recent developments?
Yes, thanks, Lainie. And so this really is an astonishing accomplishment. And as you pointed out in your opening remarks, we're really seeing staggering numbers of cases, hospitalizations, and deaths in this country. And the bright news is that we are on the verge of having a vaccine that can be administered to people in the United States. So what happened yesterday was really a milestone in this. An independent advisory group of experts to the Food and Drug Administration, they're called the Vaccines and Related Biological Products Advisory Committee, held an all-day public hearing and debate to discuss the pros and cons of the Pfizer messenger RNA vaccine, and ultimately voted for an emergency, to recommend an emergency use authorization for individuals 16 years of older of age in the United States. What they highlighted, they reviewed in detail the data from the Pfizer trials, particularly the large phase 3 clinical trial that's still ongoing. They highlighted the high efficacy that we had heard about before, 95%. But these results were found across diverse participants in terms of age age categories, in terms of racial and ethnic background, and in terms of underlying comorbidities. There's still much to be learned about the efficacy and safety of this vaccine in particular subgroups, but it looks really good across the board. They also discuss the safety issues, and we know that there are side effects, what we call reactogenicity, associated with this vaccine that can include soreness and fever, headaches, joint pains, muscle aches. All of this is part of the inflammatory response to the vaccine. It's expected. We see this with other vaccines, and it can be treated with anti-inflammatory drugs. These are transient, lasting 12 to 36 hours, and don't have any long-lasting side effects. The committee also highlighted some of the unknowns. We still do not know the duration of protection. We still have to learn more about the use of this vaccine in pregnant women and in children, and we'll learn more about this going forward. We still need to have longer-term follow-up on any potential rare adverse events that may occur longer after receiving the vaccine. We also learned that there's some protection after a single dose of the vaccine. There's going to be no change in the recommendations. This vaccine should be given in 2 doses, but people will benefit from some protection even after a single dose. Also in the news has been the fact that the United Kingdom has rolled out the Pfizer vaccine, the same vaccine for which we heard about the recommendation on emergency use authorization. And one thing making news is that 2 healthcare workers who had prior history of severe allergic reaction, what we call an anaphylactic reaction, 2 individuals had a similar type of reaction following the receipt of the Pfizer vaccine. We're going to need to learn a lot more about what are the components of the vaccine that may induce this type of allergic response, and understand better what the frequency of these types of adverse events are. These were not seen, interestingly, in the large phase 3 trial in which more than 20,000 individuals received the messenger RNA vaccine. So what are the next steps here in the United States? As you mentioned, Lainie, we're expecting the Food and Drug Administration to take that recommendation from the advisory group and actually approve an emergency use authorization for this vaccine. That could come as early as tomorrow, Saturday. In parallel with this, the Advisory Committee on Immunization Practices is going to meet, make their recommendations for the Centers for Disease Control and Prevention. And I expect that by early next week, we're going to have an emergency use authorization from the FDA and recommendations from the CDC on this vaccine. And within a day or so, we're going to see these vaccines delivered to sites within states throughout the country, and they will begin to administer this vaccine to those high priority groups. Those include healthcare personnel and residents and staff of long-term care facilities.
Thanks so much, Bill. And I also want to thank our audience. I can see lots of questions coming in. And so now we're going to turn to the questions that you've been submitting, and we will have our experts, Brian and Bill, answer them. So Bill, I'm going to start with you. And you mentioned in your remarks pregnant women, and we receive a lot of questions about vaccination and pregnant women. So the question is, will it be safe for pregnant women or those planning to become pregnant in the next few months to receive a COVID vaccine?
Yes, this is a very important question. And right now, I will say we don't have all the evidence we would like in order to answer questions around the safety and efficacy of this vaccine, this messenger RNA vaccine, in pregnant women, women who plan to become pregnant, and lactating women. We will learn more as we go forward. As many of the listeners know, pregnant women were excluded from the phase 3 trial deliberately, but there were some women who became pregnant during the course of the trial. So we're going to learn more about any potential adverse events related to the vaccine. I don't anticipate any, but this is something that needs to be looked at very carefully. So right now, we certainly do not want to exclude high-risk pregnant women in this first allocation of the vaccine, but we also need to be very cautious about until we learn more about administering the vaccine to pregnant women. So right now, for better or worse, this needs to be an individual decision with a particular woman and her physician about the pros and cons of receiving the vaccine. I would say if a pregnant woman or a woman planning on becoming pregnant should really consider other public health measures such as mask wearing and distancing, avoiding large gatherings as a way to prevent infection.
Thanks, Bill. Brian, question for you. You mentioned antibody treatments. Can you talk us through the data, even if it's preliminary, and what do we know about antibody treatments?
Sure. So there have really been two monoclonals that have gone under the emergency use authorization, and those are the ones that we have the best data for. Both of them in small studies in outpatients showed that you could reduce the risk of hospitalization if you received these antibodies before you became severely ill from COVID-19. However, in larger studies that were done on inpatients who were already sick in the hospital with COVID-19, both of those studies were stopped early because the monoclonal antibodies did not have any signal for improving outcomes and may in fact have had a signal for harm in certain subgroups of patients. So right now, the emergency use authorization for both of these antibodies is directed towards people who are older, so age 65 and older, or have other risk factors that we know are associated with severe disease from COVID-19, such as obesity with a body mass index above 35, if you have chronic diseases like diabetes or chronic kidney disease, if you're immunosuppressed, or if you're on medicine that suppresses the immune system for another reason, or if you're over 55 and have heart disease, high blood pressure, or chronic lung disease. Those are the populations that we're targeting right now with these therapies. And it's too soon to know what impact they're having. Number one, we haven't been able to get them to a wide number of patients throughout the United States. There's only several 100,000 doses of this compared to people who are infected right now. But we are here in Baltimore, for example, partnering with University of Maryland and Johns Hopkins at the convention center. They are actually an infusion site where physicians can refer their patients to get monoclonal antibody therapy if they meet the criteria that I outlined earlier. So I would say it's still a little bit early to know if this is really going to make a big dent in the current surge. We need more data, which is why it's not formally FDA approved, but it's an EUA, but there was some initial signal that it might prevent hospitalization in people if you catch someone pretty early. So the average time or the median time that someone received these drugs in the studies for outpatients was 4 days. And since it's an antiviral medicine, it probably works better if you get it early. So the earlier that someone gets it, the more likely it is that it's going to have a benefit if we ultimately learn that it does in fact prevent hospitalization.
Thanks, Brian. And follow-up question for you about the monoclonal antibodies. Do you have a sense of how widely these infusions are being used, perhaps from your colleagues in other parts of the country?
Yeah, so many health systems have partnered with state health departments and with Operation Warp Speed to ways to distribute these vaccines. It's not as simple, or sorry, not vaccines, these monoclonals. They are infusions, so they take several hours to administer. And so one of the big limiting factors is having a safe space where you can bring in someone who is known to be COVID positive, and you can monitor them for several hours while you put in an IV, you give them medication, and then monitor them after the infusion to make sure that they haven't had any infusion related reactions. So that's a really, the two important limitations on how widespread these monoclonals are is, number one, we don't have that many of them to give. But number two, our health system is already really taxed, and having the space and the staff to be able to administer these is a challenge. So we're limited in the number of infusions that any place can do per day.
Thanks, Brian. Bill, question for you. Can you please speak about the storage and administration of the new, just shy of an EUA Pfizer vaccine?
Yes, this is a really important question. And the messenger RNA in general is broken down quickly by heat. So the Pfizer vaccine in particular has an ultra cold chain requirement, meaning that vaccine has to be stored at -70 to -80 degrees Celsius, which is about 103 degrees Fahrenheit. This low temperature can really only be achieved in special freezers, ultra low temperature freezers. And so some hospitals and facilities have purchased these ultra cold freezers. But Pfizer has also manufactured storage and transport containers that can hold, on the average, about 1,000 to 5,000 doses of the vaccine. They have very, very careful temperature monitoring and GPS monitoring. And that's what's going to allow the Pfizer vaccine to be distributed next week, which we're going to see around the country. And that's going to require special handling by the airports and airlines to get these vaccines out to where they can be delivered. But there are limitations in terms of getting that vaccine to really remote places where only, say, a few doses, maybe even a couple hundred doses can be delivered. That's going to be hard. What's going to make what's going to be more feasible with the Pfizer vaccine is delivering vaccines, for example, in healthcare facilities or hospitals where they have the capacity to store that vaccine at that doses, or perhaps even at long-term care facilities. But it will be more of a challenge in getting the vaccine out to more remote distribution or administration centers.
Thanks, Bill. No surprise, lots of vaccine questions this afternoon. So another one for you: are either the Moderna or the Pfizer vaccines considered to be live vaccines?
Right. This is a really important question, and the answer is no. There is a long history of developing vaccines by what we call attenuation, live attenuated vaccines. That really refers to the fact that the virus can replicate. So, for example, our measles, mumps, and rubella vaccines are attenuated viral vaccines, but none of the front runners of of COVID-19 vaccines are live vaccines. Messenger RNA is just a small piece of it's really just a small piece of the genetic code that encodes for a part of the spike protein that Brian alluded to earlier. There are the adenoviral vectored vaccines, such as the AstraZeneca vaccine or the Johnson & Johnson vaccine, but these are made what we call replication deficient. So those viruses, that adenovirus vector that's delivering the spike protein gene, also does not replicate within our cells. So the answer is no. None of these are considered live viral vaccines.
Thanks, Bill. I have a question for Brian, but I promise you, Bill, I'll be back in a moment. Brian, personal question for you. As a frontline provider, are you planning to get a COVID vaccination?
Yes, absolutely. So, I've been telling people that I wanted to see the data, and I wanted to see what the FDA committee has looked at, and the FDA released all of its analysis of the vaccine data that was submitted by Pfizer, and I'm assuming we'll do the same for Moderna. And as soon as the vaccine is available, I plan to get vaccinated. We have a system in place. We don't anticipate having enough vaccine for all of our frontline healthcare providers up front. So there'll be a process that I'll go through here at Hopkins, and when my number comes up, I plan to get vaccinated.
Thanks, Brian. As I said, many vaccine questions today, so I'm going to jump back to Bill now. Bill, this is a question that speaks to a bigger issue with vaccines and the history of vaccines, and it concerns equitable access. What can you tell us about ensuring equitable access to the COVID vaccine, both within the US and globally?
Yes, these are really important questions, and there have been a lot of discussion and thinking about equitable access of vaccines, again, both here in the US and globally. What we want to do is, well, let me say, eventually there will be sufficient doses of vaccine in the United States for everyone who should and wants to get it. But that's not going to be until mid to third quarter of 2021. So what we need in the interim is a process for determining who should get the vaccine first. And there have been a number of efforts about thinking through the ethical principles that underlie that, including by the Center for Health Security here at the Johns Hopkins Bloomberg School of Public Health, as well as by the national academies. And that underpins the decision-making around the allocation process. And so that decision is made by who's at greatest risk of infection and severe disease, and who do we need to preserve for societal functioning. And that accounts for some of the historical inequities that we have in the United States and globally in terms of people being accessing this vaccine. So I'll say in the United States, it's going to be very important. And we know that that communities of color, Black and Latinx communities have been particularly hard hit by this pandemic, and we need to be sure that they get the vaccine and that we overcome some of the mistrust and lack of confidence in the vaccine. So there are enormous efforts ongoing, and that will continue to be to ensure both the supply side of the vaccine and the demand side, the confidence and trust. Globally, it's a much more difficult process, and some of the wealthier countries have made bilateral agreements with the vaccine manufacturers and purchase large volumes. I'll just end by saying there is an effort led by Gavi and WHO and something called CEPI. It's called the COVAX to try to ensure that there's equitable distribution of vaccines across countries as well.
Thanks very much, Bill. And I should mention also that on our site, on coronavirus.jhu.edu, we have a section on vaccines with lots of dynamic content, including some that Bill himself has authored. So that's a great additional resource for information on these issues. We are coming up quickly on 12:30. I'm going to try to sneak in one or two more questions. Bill, how long after receiving a vaccination would you expect someone to have immunity?
Yes, this is a really important question. And so the first answer is that the way the trials were designed, the phase 3 trial, particularly the Pfizer, they looked at protection against any COVID disease, mild, moderate, severe, and they started that clock 7 days after receipt of the second dose. So that 95% efficacy that we talk about, that's starting 7 days after the second dose. However, their trial did show that, that there was protection starting after the first dose, maybe 10 to 14 or 12 to 14 days after the first dose, maybe about 82% protection after first dose. So there is some partial protection, actually substantial protection after the first dose. The real protection comes starting 7 days after the second dose.
Thanks, Bill. So Bill and Brian, I have a final question, and I'm going to invite you both to weigh in on it. What do you believe would be the most effective strategy to induce the public to get a COVID vaccination? Who would like to go? Bill, you want to go first?
I can start. It's a really important question and a complex question. There's not a single thing. What we need to do is find the influencers within each community. Who does the community trust? Who influences that community? And we need to have those individuals really promote and be advocates, vaccine champions going forward so that they're trusted voices in the community.
Thanks, Bill. Brian, anything to add?
Yeah, I would just have to be transparent. We need to see the data as it becomes available. We need to be upfront and honest about, what we're experiencing as a global community as these vaccines are rolled out, so that everyone can feel confident that there's a surveillance process in place and that we all have the information we need to make decisions.
Thanks. And as I said, we're coming up on 12:30, so I'm going to wrap up. I'd like to thank Brian Garibaldi and Bill Moss for joining me today. And of course, give a big thank you to everyone who joined us in the audience and for those who submitted questions for our experts to answer. This briefing will be archived and it will be available to you on coronavirus.jhu.edu. As a reminder, we will continue to offer regular 30-minute briefings on Fridays at 12 p.m. In each briefing, we will focus on what you need to know right now about the COVID-19 pandemic, and we will have live Q&A with our experts. I look forward to seeing you at our next 30-minute briefing. Until then, thanks and stay safe.